So in trigeminal neuralgia, I remember in family medicine, I remember to have taught you about neuropathic pain. You can also regard this trigeminal neuralgia as a type of neuropathic pain, as we shall come to see in the subsequent chapters, because the management of this trigeminal neuralgia normally is managed in the same way as we manage trigeminal neuralgia. I mean, as we manage neuropathic pain. So, like I introduced it to you, trigeminal neuralgia is characterized by a unilateral electric shock-like pain. Normally, in that area, in the area of the face that is innervated with the fifth cranial nerve. So we went through this, and the anatomy, which is the fifth cranial nerve has 3 branches: V1, V2, and V3, but also the route through which this nerve traverses is the region where this nerve is going to be compromised whenever there is a problem in the central nervous system. And we named this area the Maker's Cave, which we said is found in the mid-cranial fossa. So we have the anterior cranial fossa, but we also have the mid-cranial fossa and the hind-cranial fossa. Now, the Maker's Cave, as you can see in this arrow, the Maker's Cave is found. The Maker's Cave is found in the mid-cranial fossa. So any region around here in the mid-cranial fossa or somewhere here in the midbrain is going to compromise, is going to compress this trigeminal nerve, and this trigeminal nerve is going to demyelinate. And after it has been demyelinated, the patient is going to present with these features of trigeminal neuralgia. But however, we saw that this disorder is very common in male as compared to female, and the reason I explained them very, very clearly. And we also talked about the pathogenesis, that it has various causes. Now we reached to the area where we were talking about the clinical features. So the clinical features, as introduced earlier in this chapter, is that normally trigeminal neuralgia presents with the unilateral shock-like or stabbing or electric pain around the areas that are innervated by this trigeminal nerve. However, this is not normally the case, especially in people who are having long-standing trigeminal neuralgia. If you're having long-standing trigeminal neuralgia, the pain is going to change and it is going to be dull. And in some people, normally the disease begins as pre-trigeminal neuralgia. In pre-trigeminal neuralgia, normally the patient feels aching pain around the jaw. And as time progresses, this pain around the jaw transforms into the trigeminal neuralgia. This phenomenon is called the pre-trigeminal neuralgia. Pre means before, so before the era of trigeminal neuralgia. So these are commonest clinical features. The other issues that you can see in a patient is the muscle spasm can be seen when one is having this electric shock-like pain. So the diagnosis, let's come to the diagnosis of trigeminal neuralgia. The diagnosis of trigeminal neuralgia is principally clinically. We diagnose trigeminal neuralgia clinically based on the clinical features, but however, we shouldn't consider trigeminal neuralgia as a standalone diagnosis. Normally, when someone comes to trigeminal neuralgia, what should click in your mind is, what is causing this pain? There must be a reason, because we say this neuralgia begins after the nerve has been compressed, or after the nerve has been demyelinated by a certain brain lesion, like multiple sclerosis and so forth. So you must try to find out what is causing this type of pain in this patient. So let's talk about the diagnostic criteria. So the diagnostic criteria is based on the International Classification of Headache Disorders. In the next session, which we shall actually cover in this week, we shall be talking about headache disorders. And specifically, we shall be covering migraine headache together with the cluster headache. So this, the International Classification of Headache Disorder, they are responsible for classifying these disorders and trying to explain the diagnostic criteria for these disorders. The same way we have DSM-5. DSM-5 is for the statistical manual for mental disorders. So we also have the classification for headache disorders in the Department of Neurology. So the diagnostic criteria is divided into A, B, C, and D. So in the first diagnostic criteria, one must have recurrent paroxysm of unilateral facial pain in the distribution of one or more divisions of the trigeminal nerve. If you remember, we have talked about the divisions of the trigeminal nerve. So any unilateral facial pain around this area with no radiation beyond and fulfilling criteria B and C. So any pain unilateral in the area of the trigeminal nerve fulfilling the following features, B and C. B, the pain has all the following characteristic, lasting from fraction of a second to 2 minutes. So this pain, like we said earlier, it's a very, very short electric shock-like pain. It doesn't last much time. So the maximum is 2 minutes, seconds to 2 minutes. It must be very severe in intensity and electric shock-like shooting, stabbing, or sharp in quality. But the other criteria for us to diagnose these trigeminal neuralgias, we need precipitated by non-harmful stimuli within the affected trigeminal distribution. It must be precipitated by non-harmful stimuli, and it must not be better accounted for by another headache disorders, like migraine, cluster headache. It must not be associated with any types of these headaches. So this is the diagnostic criteria. But the very important aspect that you need to know is the classification. This criteria is trying to tell you that we have the classification. So the classification of trigeminal neuralgia is classified into 3 parts. And normally, this criteria, what we are trying to talk about is called idiopathic trigeminal neuralgia, because normally in idiopathic, you don't find out the cause. But if the cause is found out, then the diagnosis is that cause. If it is the acoustic neuroma causing the pain, or it's multiple sclerosis causing the pain, then the diagnosis is multiple sclerosis and not trigeminal neuralgia. Trigeminal neuralgia therefore becomes the clinical manifestation of that particular disorder. So the previous diagnostic criteria is trying to base itself on idiopathic trigeminal neuralgia. But let me tell you one thing, that as we shall be talking about the investigations of this trigeminal neuralgia, we shall come to realize that not all people become investigated, and therefore they either remain in idiopathic, or we just term them as they are having a classical trigeminal neuralgia. And normally in classical trigeminal neuralgia, patients are assumed that they are having a neurovascular compression. They are having a vascular disorder that is trying to compress the neuron. So normally people will not be investigated for MRI, neither will they have surgery. So if one has surgery, maybe craniotomy, the cranium is opened, and you find out that there is a disorder around this middle cranial fossa, then that disorder that you will find on the middle cranial fossa during surgery, that will be termed a secondary trigeminal neuralgia. If you find that there is a cerebellopontine angle tumor, like we have seen in acoustic neuroma or the vestibular schwannoma, Then if you find that disorder, that will be called secondary trigeminal neuralgia. Otherwise, if no investigation is done and the patient is having all risk factors for having a vascular disorder or a vascular disease, for example, one might be having a family history of a aneurysm in the family, maybe one died of a aortic aneurysm, then someone has a risk factor. So you can term this patient to have a classical trigeminal neuralgia if you don't have the investigation to prove the secondary cause. So remember, trigeminal neuralgia normally is going to be having a cause. If you can't establish the cause, then you assume it to be a classical trigeminal neuralgia or an idiopathic trigeminal neuralgia. So that's the classification. Now, the other issue that you need to understand is not every unilateral headache, not any unilateral pain around the face is going to be trigeminal neuralgia. We also have some other causes of trigeminal neuralgia. For example, some people get herpes zoster. For example, HIV positive patient, they will get herpes zoster on the face. This herpes zoster maybe is going to be cleared out with a cyclovir, but as you all know about neuropathic pain, even if the stimuli has been removed, the virus has left damage to the nerves, so one will continue feeling pain throughout. So the other differential diagnosis for a trigeminal neuralgia is when you are having a painif trigeminal neuropathy. And in a painif trigeminal neuropathy, one is having a continuous or nearly continuous facial pain in the distribution of the trigeminal nerve. This means what? This means that the trigeminal nerve, like we said, is supposed to last few seconds up to 2 minutes. That's the maximum. If it is beyond that, then we call this a painif trigeminal neuropathy. And the example of what causes this painif trigeminal neuropathy include disorders like acute herpes zoster, or, for example, those patients that I was trying to explain, the post-herpetic neuropathy. In the previous times, he suffered herpes virus, but it damaged the neurons. So one may continue to present with pain along the distribution of the trigeminal nerve, which we saw is the face. We also have some other disorders like post-traumatic trigeminal neuropathy. We also have painif trigeminal neuropathy attributed to other disorders, or sometimes the cause can be uncertain or unknown. So we call it idiopathic painif trigeminal neuropathy. So beware to differentiate these two types, these various causes of pain around the distribution of the trigeminal nerve. Now, this is the flow chart that is trying to show you that if a patient comes to you, how are you going to evaluate the patient? So this chart, you will go through this chart. It is very straightforward. Like we said earlier, you might want to do some investigations. For example, you do the MRI. If you do the MRI and it's normal, then think of a classical trigeminal neuralgia, or think of it as idiopathic. The causes are known. But if the MRI is abnormal, then probably one is having a space occupying lesion. Maybe is having a tumor around that trigeminal cave that you have seen in the middle cranial fossa, or is having multiple sclerosis, or is having a vascular compression of the trigeminal nerve. Maybe he got a stroke. The bleeding has occurred around the cave of the trigeminal nerve. So all these, we term them as secondary trigeminal neuralgia. So it can either be classical or secondary, or you can term it as to be idiopathic. But the other issue that we have talked about is some people will have painif trigeminal neuropathy. For example, if one comes to you is telling you the history of suffering herpes zoster in the past around the face, maybe, as you know, the herpes zoster has to go around the dermatome. For example, around the face, we have V1 dermatome, V2, and V3 dermatome. So maybe one had a herpes zoster along V1 dermatome. So when it comes to you, then you will obviously be having a continuous pain, and not this pain that we are trying to talk about that normally lasts for 2 milliseconds up to 2 minutes. So this flowchart is trying to show you how you can come up with the various diagnosis or the differential diagnosis. So we have talked about the differential diagnosis in the classification above, but we have talked about pain of trigeminal neuropathy as the differential in the previous slides. Now, what is the treatment? What is the treatment of this trigeminal neuropathy? Probably you haven't found out the cause, because if it is secondary trigeminal neuralgia, then you need to treat the underlying cause. But if you don't have the cause, you are still assuming either maybe the cause is unknown or there is a certain vascular disorder that you don't know, then the treatment of choice is going to be use of carbamazepine. So like we learned earlier in family medicine, we learned that we can use anticonvulsant to treat these types of neuropathies. So carbamazepine, you can start with a dose of 100 up to 200 milligram twice daily. This is the starting dose for carbamazepine, but you can titrate this dose 200 milligram daily. You can increase gradually, stepwise, till you reach the maximum dose. So the maximum dose is around 1.2 grams daily of carbamazepine. So that's how we treat this type of trigeminal neuralgia. Remember, the maintenance dose is around 600 up to 800 milligrams. But if the patient is still feeling pain, remember, the maximum dose is 1.2 grams. And this is the end of our presentation about the nerve disorders. I don't know if there is any question. I welcome any question. If there is any question, I welcome the question. You can put this question in the comment section. Any area that needs further elaboration? I welcome any question about the neuralgias and the nerve pause that we have talked about today.
Mara juzi nikasikia Rema anasema nyingine ipo, sijui ilipatikana, sijui nini.
Joseph Waziri anasema, Dokta, naomba urudie pathophysiology ya Berry's pause. Jamani, the pathophysiology of Berry's pause is very straightforward. Berry's pause, the problem is compression of the nerve. Now, what compresses the nerve? It can be swelling because there is an infectious process, for example, the herpes simplex virus. So after the nerve has swollen, normally it's going to be compressed by the internal acoustic meatus, because this is a very narrow opening through which the nerve traverses. But to be specific, the opening itself is not that much small, but in the labyrinthine area that you have seen here is the area that is very narrow in shape. So if the nerve enlarges, it is going to be compromised by the bones of the skull, and the patient is going to manifest with trigeminal. It's going to manifest with face facial paralysis. Now, the facial paralysis of facial nerve pause is quite different from the facial nerve pause that occurs in patients who get strokes. Now, for you to understand, yani hiki kitu ni very straightforward kabisa. Tumesema upande wa juu wa uso, kama mnavyoona upande wa juu wa uso unapokea innervation kutoka sehemu mbili za ubongo. Hii inamaanisha nini? Unapokea kutoka upande wa kushoto wa ubongo kama mnavyoona kwenye pink, na unapokea innervation pia kutoka upande wa pili wa ubongo. Kwa hiyo upande wa kushoto, upande wa kulia wa ubongo, zote zina innervate upande wa juu wa uso, kuanzia juu kwenye paji la uso mpaka kwenye jicho, zinakuwa innervated from two parts of the brain. Lakini sehemu ya chini ya ubongo inakuwa innervated na upande mmoja, na ni upande ambao huko opposite. Mfano huu ni upande wa kushoto wa mgonjwa, lakini akija kupooza atapooza upande wa kulia. Kwa hiyo ni contralateral, ni upande tofauti. Lakini kitu kingine cha kujua ni kwamba lini kutatokea shida kwenye hii ni nerve tract. Hii ni nerve root. Inaanza kwenye brain cortex, inakuja kwenye nucleus ambayo iko kwenye pons, na then facial nerve ndio inayopick fibers zinatoka kwenye pons zinakuja kwenye hii sehemu ya uso. Sasa lesion ikitokea huku juu, tuchukulie upande wa kushoto kama ninavyojaribu kuonesha hapa, upande wa kushoto wa mgonjwa, nini kitatokea? Lesion iko juu, mfano stroke imetokea hapa kushoto. Hii inamaanisha nini? Ni kwamba nerve iliyo rangi ya blue, hii sio ni blue, sio ni kijani, tuchukulie ni kijani, hii rangi ya kijani hii na hii rangi ya pink zitakuwa compromised. Kwa hiyo huyu mgonjwa atapooza sehemu ya chini, kwa sababu hii kijani imekuwa, hii nerve fiber imekuwa compromised hapa, na hakuna alternative route, kwa sababu alternative route iliyoko ina innervate upande wa uso tu, hakuna sehemu nyingine ambayo inakuwa innervated. Kwa at the end of the day, mgonjwa wa hivi atapooza sehemu ya chini ya mdomo hapa, kuanzia kwenye pua kushuka huku chini kwenye mdomo, lakini hii sehemu ya juu ataweza kufunga jicho, ataweza kukunja ndita vizuri tu. This is quite different kwenye facial nerve. Facial nerve ni lower motor neuron lesion, kwa sababu hapa motor neuron inaanzia kwenye cortex mpaka kwenye pons. Hiyo ni hapa. Lower inaanzia kwenye pons mpaka kwenye uso. Kwa hiyo facial nerve ndio inayotoka kwenye pons na kuja kwenye uso. Kwa lesion inayotokea hapa katikati inaitwa lower motor neuron lesion, na itaziblock fibers zote pinki pamoja na hii kijani. Kwa mwisho wa siku mtu atapooza juu na atapooza chini, and that is the pathophysiology of facial nerve pause, kama ambavyo amejaribu kuuliza waziri. Kama kuna swali jingine jamani.